That kickoff. Thank you, Audrey. The recording of this meeting will be posted on the board's website very soon, and TVW is also planning to stream this meeting and archive it for additional viewing opportunities. We have a packed agenda today. Really appreciate your all being here as usual. And Sue Birch, Chair of the Healthcare Cost Transparency Board, will now call this meeting to order.
Thank you, Kaylee. Welcome, board members. This is Sue Birch, and I am now calling the December 12th public hearing meeting of the Healthcare Cost Transparency Board to order. I want to give a warm welcome to everyone joining us today for our very first public hearing. And we are going to be looking at performance. I'm sorry, are we okay on sound? Good. We are going to be looking at the performance against the benchmark for carriers and large provider organizations here in the state of Washington. And I want you to go ahead and open up to that agenda. Tab 1. So here's the overview of our cost board's charge and the key role that this board plays to increase transparency and affordability of healthcare costs in Washington. Next, we're going to hear from Vishal Chowdhury, our Chief Data Officer here at hca, and Amanda Avalos, our Deputy for Enterprise Analytics, Research and Reporting. And they're going to walk us through the findings of the 2024 data call, including evaluating performance against the benchmark. They will highlight spending trends relative to the benchmark target from 2022. After their presentation, board members will discuss their key takeaways and thoughts for the future as we prepare for next year's data call. We're then going to have a short break at 2:30. After the break, we will have 3 panel presentations, the first from our consumer advocates, second from provider and carrier representatives, and third from the business and labor partners. At 3:35, we're going to open the floor to public comment. And then finally, I'll close out the meeting with a few final thoughts and call to action for our ongoing work in 2025. We are going to adjourn the hearing at 4 p.m. And I am just so pleased, before I turn us to roll call, to just say this is another kind of milestone. This is a mile marker. This is a celebration of kind of our first public, and all of our meetings are public. This is a very official, distinct kind of showcasing of the work we've done thus far. So, looking forward to the day, and there continues to be all sorts of hope about this work. Several of us just came from a national gathering and cost containment and this pursuit of transparency and really just understanding and fine-tuning and really listening to the voices of the consumers and knowing we simply can do better in the future is a very aligned commitment and efforts by many others in the country. So I will now move us into roll call. Jane Byer. Here. Thank you. Eileen Cody. Here. Let the record reflect that Lois Cook was not able to attend today. Bianca Frogner.
Here.
Thank you. Jody Joyce. Staff, let me know if Jody jumps on. Greg Marchand. Again, staff, let me know if Greg jumps on. Mark Siegel. Okay. Same for Mark. Margaret Stanley.
Here.
Thank you. Welcome, Margaret. Ingrid Ulrey, I see you in the room. Hi, here, way down there. Thank you, Ingrid. Kim Wallace, you're here in the room. Wonderful. And let the record note that Carol Williams is unable to attend today as well. And here in the room, I want to welcome our
Sue.
last board. Yes.
Sorry, it's Greg. I'm here. I was muted and
no worries,
was
Greg.
very slow.
Great. Thank you for joining us today, Greg. I also want to, I'm calling on Hanton Day, our newest board member. He's a physician, and Hanton's here in the room with us. And actually, I want to just pause for a second and let Hanton tell us, do you prefer to be called Dr. Day?
Oh, I feel free to just call me Hanton. Everybody calls me Hanton. And also, many actually in that case, they just call me. I said, "Can I call you by your HD?" I said, "Sure." Okay. So then for in the last kind of 20 years, a lot of people just call it me. I said, "Okay, I'll make HD as my personal brand." And then honestly, and the dependability and so and honestly dependable. I'm a physician by training, but I'm not practicing, clinically. But I've been in healthcare all my life, blessed with a lot of, wonderful opportunities working from hospitals, medical schools, pharmaceutical, health plan, provider system, NGO. So, very interested, deeply involved in healthcare, data, kind of clinical quality, population health. So it's a pleasure to be here with you. I look forward to, learn from all of you. Thank you.
Well, HD, I'm gonna call you that one, that just sticks. Welcome, and I hear you have pretty extensive experience down in Oregon, so we really look forward to hearing your insights and wisdom and to become part of this group. It's really a fabulous journey that we're all on, and we welcome you to join our board. All right, so that closes out our roll call.
Actually, I see Edwin Wong's here as well.
Oh, Edwin. I missed
Good to see you.
Edwin Wong. There he is over there. Edwin, thank you.
Jody Joyce is here now.
Oh, and Jody, if you're on, I think you've jumped on. You can call out Jody. And if you're speaking.
This is Jody, and I'm here as well. Thank you.
Okay, great. Thank you. So at this point, we still are waiting for Bianca, right? Who are we missing?
No, I said I was here.
Okay, who are we missing still? Mark Siegel. Mark Siegel. Okay. Let me know if any other board. Okay. All right. Let's move now into the hearing process. If you'll turn to tab 2, this is page 5. Again, today is our first ever public hearing to discuss the first ever performance against the benchmark analysis. And on page 6, more than half of today's agenda is an opportunity for board members to hear from Washingtonians impacted by healthcare costs. So this is going to be a really essential opportunity for all of us to hear, and as we keep tackling kind of the challenges and whatnot, we want to just blend in all that information. We in the packet on page 7, the directives, as I was talking about earlier, catching up. Eileen and I both had late night flights last night, so bear with us as we together. So I remind you on page 7, the establishing the growth targets, the understanding healthcare expenditures, identifying what drives the growth in healthcare costs, recommending ways to improve transparency and affordability, and evaluating the cost growth performance of the carriers and providers is our directive. And it's been a really huge undertaking. The transparency and the insight into the profile of costs of Washington is an important first step. So we also want to remind you that this is really been building off of things of the other work that's happening at other state agencies, and we're blending this in. It's really been building on our Washington leaders' dedication and robust efforts to expand access to insurance coverage, increase care and quality and value, and strengthen the delivery system. We know we have more work to do to achieve these goals and to make care more affordable and accessible for all. Since its inception in 2020, the board has conducted numerous analyses about total healthcare expenditures and trends in cost growth. This includes an analysis of the cost drivers, the assessment of primary care expenditures and hospital expenditures, and the disease stratified expenditures. And using economic progressions back in 2021, projections back in 2021, the board established a benchmark, those target rates of growth for healthcare costs. And we decided to set targets that would help keep healthcare cost growth below the growth in consumer purchasing power and growth in the state economy. So today we're going to focus on the orange rectangle. For the first time ever, we'll complete our legislatively mandated charge to assess provider and taxpayer performance against the benchmark. So there you see on page 10, this is our assignment. And again, we This has been very collaborative work and effort, and the board has been doing great kind of level setting the foundation for this work by determining the benchmark and making decisions regarding methodology. We also want to thank all the carriers for all of their voluntary data submissions. We saw process improvements this year with timelier data submissions, became less painful than last year. And, there was less back and forth in the resubmissions, and we'll get better. This will get easier and more streamlined as the years go forward. Keeps everybody on our toes. And we recognize there's context behind each data point, which we won't have time to delve into today to too great a detail. I remind you that this board, we really try to stay in that macro space. But this is an important step in understanding costs in Washington. We also recognize that the performance against benchmark analysis tells us about cost growth. It does not tell us about the affordability of healthcare for Washington individuals and families. And we know that costs are prohibitively high for far too many of our neighbors and family and friends. And we'll hear more about that this afternoon with our panel presentation. So with that, I'd like to welcome Vishal and Amanda to the presentation. They have just been stellar in this process, learning and directing as we've come along and just really growing into this new body of work over the years. So Vishal, I'm going to turn it over to you. And I remind board members now we're moving into tab 3. Vishal, over to you.
Thank you, Sue. And thank you for the board, to the board for having us and allowing us the opportunity to present. Before I get started, I want to acknowledge there's a couple of team members from our analytic team who are probably in the room. And so I want to acknowledge Jinping and Cheryl. They've done all the work and their team has done all the work behind this. I'm just a talking head. There in the board packet is an executive summary of the analysis and the findings. That's what you see on the screen right now. I'm not going to go through that. We'll just go through the slides. Given the amount of time we have for our presentation, I want to make sure that the board has enough time to talk through and discuss the findings. As an outline, we'll just go through some highlights and just a high-level summary of our findings. Then I'll hand it over to Amanda, and she'll walk through the details behind spending, the per member spending growth, which is the benchmark, as is our charge, presenting it from a statewide perspective, also by markets, and then by the large carriers and large providers. Finally, we'll go over some spending trends analysis over this time frame, and then close out the slide deck. Next slide, please. This is a repeat of the slide that Sue shared with you. Once again, the highlighted one is we have 7 distinct analytic work streams that support the cost board. This work stream, I like to say, brings us the closest to home, if you will, in terms of true numbers as far as the macro level healthcare spending in Washington goes. Most other analyses take a sample, sometimes a large sample, to present a picture, or rely on high-level estimates, gathered from different sources. The performance against the benchmark, this analysis is based on actual spend data that is gathered as a result of the data call from the carriers and other sources. So if anyone were to ask me, I would rely on the total expenditure numbers coming out of this report as probably closer to the reality. Next slide, please. I mentioned the multiple data sources. This is a very busy slide. I'm not going to explain it in much detail. But when we talk about total expenditure, that is the top box that you see, the total healthcare expenditure, or THCE. That consists of 3 distinct buckets. There's total medical expenditure, which is really what you and I typically refer to as healthcare expenditure, which is, by either paid through claims or non-claims, but essentially going through insurance companies or others to providers who care for patients. Then there's NCPHI, which is the net cost of private health insurance, which in a simple way is it presents the cost of doing business for the insurance companies. And then there are some other spending buckets, like the Veteran Affairs, the Department of Corrections, and the Labor Industries, which is the employment related claims. Those are also healthcare expenditures, but they don't neatly fit in one of the other buckets. So there will be other spending. And the slide deck here will start with the total healthcare expenditure level analysis, but the data that are presented by market, by carrier, and by organization, they are limited to the total medical expenditure claim. That's the claims plus non-claims data. Next slide, please. This is just a reminder, Sue mentioned it, but this is the first time that the board will see a cost growth analysis against an actual benchmark year. So we'll present data collected for the year 2022, for which there is a growth benchmark that's set by the board at 3.2%. Next slide, please. The performance metrics that we use, again, here are the aggregation levels. So you'll see in that little chart that we have that the only place where we look at total healthcare expenditure is at the statewide level. The rest of it is about the total medical expenditure, which doesn't include, obviously, the total healthcare, the net cost of private health insurance and the other data sources. But that's where we can get into some level of analysis of the stratification between markets, carriers, and large provider organizations. Also important to understand that the methodologies around attribution, truncation, risk adjustment around age and risk, and the confidence intervals are actually done at the carrier and large provider organization level, not at the statewide or market level. Next slide, please. So now we get into the highlights. And so the top line first, the cost growth from 21 to 22, the per member cost growth was at 3.6%. You saw that the benchmark target is 3.2% for 2020. So that is, you could say that, oh, that's pretty close. And that will be, factually correct. But market-wise, only the Medicare market by itself exceeded the benchmark. When we look at the carriers and large providers, 5 out of the 12 carriers that submitted data and only 5 out of the 28 large provider organizations exceeded that 3.2% benchmark. On the other spending side, the VA spending growth also increased or showed much above the benchmark. We'll go through that in a little bit of detail. What we realized as we were doing the analysis was that looking at just 1 year by itself may not present a full picture. So next slide, please. The team also looked at the 2019 to 2022 growth trends, which also encompasses the dip and spike, if you will, that we experienced during 2020 and 2021 related to the COVID-19 pandemic. So that helps us understand some of the anecdotal information that we've had for a little while now from the markets, but also, looking back, some of it is corroborated by the data that we'll be seeing today. Just if we go back to the previous slide real quick, the last bullet point in this, there was a per capita Medicaid spending decrease due to a decline in other claims, but it was more than offset by prescription drug spending. So it's just a nuance about how the Medicaid spend has happened during this time frame. And we're still looking at the factors behind it, but some of the contributors could be related to the expanded roles during the pandemic with the expansion and then the unwinding that started afterwards. Although that's probably that's in 23, 24, not in 22. Okay, next slide, please. Now, as we look at just the 2022 overall spending, on the next slide, you'll see that the total healthcare spending increased to 55.1 billion in 2022. As compared to the last time the board saw the data, that was for 2019, and that was 48.1 billion. So the total growth between 21 and 22 is 5.3%. And when you look at the spending in 2022 itself, that's the chart on the right, out of the 55 billion expenditure, you'll see that almost 89% of that is total medical expenditure. So when we do the disaggregation of this data and stratify for the carriers and the markets and the providers, that's why we use the total medical expenditure, because that provides a very good representation of the overall spend in the market. Next slide, please. Also, I mentioned that during the pandemic timeframe, there was a dip and a spike. So from 2019 to 2020, in the middle of the pandemic, there was quite a significant dip in utilization of services, healthcare services at large. The larger drops we're seeing in the Medicare and the commercial arenas. In 21, we saw was that the bounce back, if you will, more than compensated for that dip in 2020, if you look at an aggregate trend perspective. So 21 to 22, what we see is somewhat of a stabilization, or the beginning of the stabilization of the growth trends. And Amanda will go over that in the next few slides. So on the next slide, I'm going to hand it over to Amanda. Thank you.
Thank you, Vishal. Hello, my name is Amanda Avalos. I'm Deputy for Enterprise Analytics, Research and Reporting here at the Healthcare Authority. So now, for the first time ever, we're going to be looking at the Washington 2022 performance comparison against the benchmark. So with this slide, we're going to start by looking at the spending per member at the state level. So here are healthcare expenditures per member per year between 2017 and 2022. And again, in the middle, you can see some of the expected declines and changes due to the pandemic. Of note here, the 21-22 per member spending increased by 3.6% for the state, reaching 7,702. And to add a little perspective to that, this is roughly the equivalent to 1/4 of the annual income for a minimum wage worker here in Washington. Next slide, please. All right, so here is the same data, but we have some additional figures highlighting the cost growth per member over time, recognizing that we still have the pandemic-related shifts in the middle. But if we step back and see the statewide healthcare cost growth over the entire time period between 2017 and 2022, it is 21.8% increase. Next slide. All right, so this slide focuses on statewide changes in the year-over-year expenditure growth per member. And so really that red line that you see, that's representing the benchmark that was set by the cost board. So a key point here is that although the year-over-year growth is not as high as we've seen in previous years, actually you can look back to 2017, 2018 for the increase there of 6.6%. But for the most recent year, the 21-22, the statewide growth 3.6 slightly exceeded the performance benchmark that was set for 2022. Next slide, please. All right, so what we're seeing here is a comparison of state total healthcare expenditure per member per year growth between 2018 and 2022. So this is Washington in comparison to Oregon and Connecticut and other states that have similar data available. These are states that are tracking cost growth through similar cost containment efforts. So you can see Washington is highlighted in orange and generally is showing up in the middle as we look from these different time periods throughout. And next slide. All right, so this is total healthcare expenditure breakdown per member between 21 and 22. There's a lot of information on this slide. So starting on the left side, you can see each market. You can also see hca. Again, that's the net cost of private health insurance, which includes things like advertising and administrative costs. As you're looking in the middle, that is the percent of total healthcare expenditures. So one thing to note here, an example, Medicare, even with a relatively smaller increase, they can really move the state as a growth driver because you can see here it's 32.5% of the state spending. And then if you look over to the visualization on the right, this is the overall growth rate. I mean, you can see here that the overall growth rate is driven by accelerating growth in per member spending for Medicare, NCPHI, and Veterans Affairs. And one other thing I'd like to note on this slide, you can see Department of Corrections here at the bottom on the left. They do have higher per member spending, but I do want to note that that does really include comprehensive care for an aging population and also includes dental, as well as VA includes dental. And because standalone dental programs are not collected in the data call, you won't see that elsewhere. But what you can also see with Department of Corrections, because the covered population is very small, that's 0.5%, it does not significantly drive the overall state spending. All right, and next slide, please. All right, so what we're looking at here is growth by each market. So commercial, Medicare, Medicaid between 21 and 22. So this slide really helps demonstrate the difference between the growth in aggregate total medical expense. You can see that on the left side, and then the growth per member, which you see on the right. So the slide on the right is normalized to account for changes in the covered population size between the years. So in this particular case, you can look at Medicaid, the increasing Medicaid enrollment during the 2 years. And that's really due to some of the federal policy changes and enrollment changes related to the pandemic. But that really impacts the per member growth trend. So you can see that very clearly in the slide. All right, next slide. Thank you.
Amanda, can I mention something on the previous slide real quick?
Certainly.
Just important to note that the growth benchmark is applied at a per member per year level, not at the total expense level. So if you've seen, the total expense grew from 21 to 22 by 5.6%, but the per member growth was 3.6% overall. It's been a topic that's caused some confusion, so I thought better to clarify here. Thank you.
Thank you, Vishal. All right, so next slide, please. All right, so we're now moving into the large provider organizations' performance against the benchmark. So here you can see each organization's name. Along the left side in gray, we've got the total medical expense growth rate per member, and that's between 21 and 22. You can see that red dotted line that represents the benchmark of the 3.2% growth. And so being really on that left side of the line is showing a lower growth rate, which is the goal here. The majority of provider organizations met the goal, and you can see that in the green. Although 5 out of the 28 exceeded the benchmark by having higher growth rates. And you can also see the indeterminate. So I'm going to draw attention to the appendix one more time because there's a lot of detail behind this data. So you can find information on attribution and risk adjustment in the appendix. So please look there for more of that detail. All right, next slide, please. All right, so now here we have carriers' performance against the benchmark. So it's laid out in a similar manner as the last visualization. We have the total medical expense growth rate per member for 21 and 22. You can see that half of the carriers met the performance goal. And then 5 out of 12 carriers exceeded the benchmark by having higher cost growth rates during this time period.
Amanda,
Yes.
this is Sue. Can you clarify Community Health Network Group, is that CHPW?
Community Health Network Group. I would defer to Cheryl if she's in the room. Oh, Vishal?
Yeah, that is the provider organization side of CHPW. So
It must be the holding group of CHPW, or they're not on this.
CHP is the carrier.
Oh,
And they were one-to-one.
okay, thank you.
But is the Primera Cross group, would that include both Primera and Likewise? So it's at the holding company level rather than at the carrier specific level?
We'll have to verify that.
Okay, thanks.
I can't hear if there's an additional question in the room.
Say it louder.
It's just muttering.
Okay.
It looks like if the reference is to Cambia, that's the holding company. That's not the licensed carrier. And then like United Health Group, there's United Health Insurance Company, which is the commercial entity.
Yeah. You need to speak at the ceiling really loud. Sorry.
yeah, that's a good clarification, Jane. The carriers denoted here are the parent companies.
Holding companies.
The holding companies, yes, aggregated at that level.
Thank you. We were just trying to kind of like, you have Centene, we call them coordinated care of Washington, Molina's Molina, but we were just trying to make certain we understood who's who there.
And so, I mean, the question that follows up on that, if you take something like United or Community Health, right? Community Health has their Medicaid book of business. They're also in the individual market. United is Medicaid, individual, small group, large group. So this is their cumulative experience across all of their books of business. Is that what we're looking at? Okay, thank you.
Yeah, and this is Jody, just a clarification. So Community Health Plan of Washington, all of their insurance products are overseen by the board that's called the Community Health Network. And so that
Got it.
Yeah.
Okay, so it's still like a holding company. Okay.
So that the important thing about that is that the breakout at a breakout level, it could look different.
It could look different for different lines
For
of
different
business.
lines, exactly.
Right,
Yeah.
because we saw, right, commercials are driver, Medicaid flat.
Right.
So the question is, would these benchmarks
Look different if it was broken
Right.
out by.
like Molina is massively Medicaid with a little bit commercial. And same with Centene, right? Coordinated care is way more Medicaid than commercial. So, I mean, it would be interesting to see each of these entities sort of distinguishing Medicaid from commercial. That would be really interesting.
Yeah, and Jane, that detail.
Medicare.
And Medicare, so
right.
don't forget Medicare.
That's right.
In
So
the
if I can jump in real quick,
Michelle, I'm just saying, this is our first year, but this one's going to be captured in our discussions. So thank you for letting me distract us. And why don't this will come back around in our discussions here in a little bit.
and I just wanted to respond to say, Jane, yes, all of that detail is available in the data, and there's a ton of analysis that underlies these few slides that the board is receiving. Absolutely happy to drill into more detail. Something that Jody pointed out on the side also, Medicaid dental expenditures are also included. So only the standalone dental plans are not required to report their data. But if it's part of a broader offering, like in Medicaid and DOC, those data are included in this report.
Yeah, and Sue's absolutely correct. If we're going to break out by line of business, we should report for Medicare as well.
Well, and then in the future years, I'm sure we'll be able to dissect Medicare Advantage versus Medicare fee for service, because we've seen three of them exit Medicare Advantage, and so it would be very interesting to look at their mix and how. Yeah. We're just trying to understand it. We're curious, so it's just great that we have this baseline information this year. Why don't you keep going, Amanda and Michelle?
Certainly. All right, so next slide, please. So we'll shift now and look at spending patterns going back to 2019. Next slide. All right, so this is the same visualization we saw previously, but this has more years of data. So it's the total healthcare expenditure breakdown per member, by market, and other spending between 2019 and 2022. So you can see each market on the left side and other spending, and then between the 2019-2022 expenditures. Also in the middle is the proportion of total healthcare expenditures. And you can see, again, the other spending is a much smaller proportion of the total spend. And one of the key points on this slide is on the right, the overall growth rate, and the growth drivers for this time period being commercial, Medicare, and VA. All right, so this slide highlights really how growth shifted before and after the pandemic for different markets. So you can see Medicaid on the blue dashed line. Initially, Medicaid had higher growth, and that has since declined. Really, since the pandemic, commercial growth, which is that dashed purple line, outpaced all other markets here in Washington State. Next slide. All right, so this is a comparison around healthcare growth within markets. So we saw a similar slide, but this has a market breakdown in Washington, comparing to other states between 2019 and 2022. Again, Washington is identified in the orange. So the key takeaway here is that Washington and all the other states are seeing a similar pattern where the average per member growth rate in the commercial market is above the average growth in other markets. And next slide.
Ask a question, I'm sorry, about the commercial market.
Certainly.
Is the commercial market reporting for expenditures for just fully insured lives or fully insured and self-funded, Vishal, or others?
All of it.
All lives?
Yes.
Okay, doke. Thank you.
Yep.
So here we're looking at service categories cost breakdown, and we're at the state level here. And so the visualization in the middle is the statewide per member spend growth for each of these categories. You can see the trends between 2017 and 2022 with some highlights on ones that you can really see rising. And then on the right is the contribution to year-over-year growth. And there you can see the highlights of the declines in hospital inpatient, and that's represented in blue. Really, the key point for this slide is top cost drivers for the growth include prescription drugs, non-claims, and hospital outpatient at the state level. Next slide, please. All right, so now we're going to dig into each market and look at contributors to the total medical expense over time, starting with the commercial market. And so let me orient you to this graphic. So the y-axis is showing the percent change to the per member per year. And then you have the x-axis that is per member per year spending for 2020. And then the size of the bubble corresponds to the contribution to overall growth during the time period. And so what we see here is that in commercial market, the top contributors are prescription drugs, hospital outpatient, and professional specialty. All right, so now we're switching and we're looking at the Medicare market. And again, the same visualization, y-axis is the percent change to the per member per year, and the x-axis is the per member per year spending for 2020. And then that size of the bubble is the contribution to overall growth. And so here we see top contributors to Medicare growth are, again, prescription drugs and hospital outpatient, which is similar to the commercial market we just saw, but also in non-claims. And so non-claims, that can be performance incentives, capitation payments, risk settlement, and direct payments. And next slide. And so now we're moving on to Medicaid, same time period, same visualization. And we're seeing similar findings to other markets. So with prescription drugs and non-claims as the top contributors to Medicaid growth. And next slide. All right, so moving to wrap up, a few key points to leave you with. The 2022 statewide healthcare cost growth was the slowest since 2018, but slightly above the 3.2 benchmark that was set by the cost board. And again, however, just looking at the most current year-over-year data doesn't really tell us the full story of Washington cost growth. Because we saw in 2019, 2022 spending growth per member driven at that time by commercial and Medicare markets, as well as VA spending. Next slide, please.
Can I go back a couple of steps? I'm sorry.
Sure.
Can we go back to the top contributors to Medicare growth? So the non-claims, when I heard you saying like performance incentives, indirect payments, is there any chance that the non-claims growth is attributable to the growth in Medicare Advantage, so that you have people going from traditional Medicare where like performance incentives, indirects don't play as great a role to Medicare Advantage where they might? What do you think about that?
So I think, potentially, we may be able to look at that if I think we have Medicare fee-for-service separately. So that might be something that we could dig in to see a little more in a detailed level.
Yeah, when we've looked previously, Jane, the non-claim side of this, especially for Medicare, is primarily those incentives and value-based arrangements. And that includes for folks in MA plans or traditional fee-for-service. But we can dig into this more if you would like.
Vishal and Amanda, Eileen asked me, is that like where gym memberships or some of those perks off of Medicare Advantage are?
I said my gym membership.
Yes, non-claims is a category that captures some specific incentive-based payments. There is that other category called other claims that are claims other that captures a lot of the other. It's a catch-all. So the gym memberships, Eileen, might be in that bucket as opposed to the non-claims. But I honestly don't know the answer to that. I have to go look. I'm speculating. Just one thing, and we'll probably provide an updated deck with a correction. The x-axis should have had the notation of PMPY spending 2022, not 2020, because this is being based to the growth rate from 29 to 22. It's a typo. Apologies for that.
And then can I just clarify too that the long-term care is acute? It's acute long-term care. It is not custodial or home and community based. It's medical long-term care.
You're correct.
Okay, because I want to make certain that people don't think that our whole long-term care picture in the state is represented here. Okay, thank you.
Yep, that's correct. And we are working to get more comprehensive long-term care. And so hopefully with the next data call, that will be available to us. All right, so we could go to slide 30. Yes. So a few more highlights to share. Top contributors for growth for 2019 to 2022 include prescriptions, non-claims, and hospital outpatient. There was a decrease in per member Medicaid spending between 2019 and 2022. And then lastly, we are seeing that overall healthcare costs in our state are increasing over time. Between 2017 and 2022, Washington healthcare per member spending increased 21.8%. Next slide, please. All right, so this is the conclusion of our presentation on the performance against the benchmark. There's a lot of detail that we didn't have time to go into. I'll mention the appendix one more time. And then, of course, there's some email contact information if you would like to have any questions directly to the staff or like to learn more. You can find the emails here. Thank you.
Jill and Amanda, thank you so much. I'm going to move us quickly now into the discussion by board members because, boy, is this exciting. There's a lot of rich content here. I'm going to start us off by taking us back to the slide in comparison to the other states. I believe it is 16, the overall growth across states. And breakout of it. I'm just curious, we're right above, oh, I'm sorry, slide 24, average growth across states by market. And it strikes me that both Oregon and Connecticut and Rhode Island have significant primary care initiatives. Is that, do we have that level of, I guess we don't have that level of breakout yet around primary care in these other states. But isn't that correct, Jane, that they've got strong initiatives going on in primary care?
Primary care medical home.
Yes.
You know, Rhode Island.
And they were thinking PI states with Medicare basing in enhanced primary care. Anyways, it's more of a comment than a question, but it's something for us to kind of look at because I do think this is really powerful to look at these other states. And I know this is in the commercial market, but where, and certainly Greg has been very involved with the Alliance and PHH, and where Healthcare Authority has been trying to push more primary care for Washington and for this board too, setting kind of that 12% target. It's just something to think of our first year data point. Go ahead, Greg.
Well, Sue, I was kind of thinking along the same lines as you, and I'm wondering, what the primary care spend is in each of these states. Because we could look at it whether there's initiatives, but also just by spend and see if there's a correlation to overall performance.
Yeah. This is, again, real rich conversation for staff to be thinking as we go forward. So it's the point of this time. What other comments or questions or observations are people seeing?
Sue, okay if I go?
Yes.
And you can guide me if you don't want to spend a lot of time on this, but I'm very perplexed by the non-claims category being such a driver. I mean, it just seems like if it is really such a driver, it just doesn't make sense to me. And if it's incentive payments driving a big portion of that, usually the incentive payments are for better performance. So I can't reconcile that category.
Yeah, Greg, you might have been an accountant in a previous life because they always hate other, and it will be interesting in the years to come for us to really try to refine this non-claims bucket, because I would agree that we need to, again, bringing transparency and understanding, we just kind of need to keep knowing if it's all Eileen's gym memberships or what is it?
Well, and also the fact that it's so, right, Medicare, it's 3%. Commercial, it's 1.1%, and Medicaid, it's what, less than 1%? Right. So what is it? What's happening in Medicare? That's why, Greg, I was trying to think, could it be that more and more people are doing Medicare Advantage? I don't know.
So Jane and Greg, great question. And I think correlating that with performance is absolutely something that we should do. Jane, I did look, that is primarily the bundled payments. So incentive payments and like value-based plans, especially for, and Medicare fee-for-service and MA both have those arrangements with providers, and that's where the bulk of that is.
Did I see you're ready to go?
Thank you. I'm going to talk loud to the ceiling. Inpatient hospital versus outpatient. Looks like the trends are different across Medicare, Medicaid, commercial. Can you speak to those differences, what's behind them, and remind us of how we're defining outpatient?
Amanda or Vishal, do you want to take that, or do you want me to restate it? You're both muted. Oh no, maybe Amanda's not. You've got them speechless.
Yes, I think I caught that. It sounds like understanding the definition of outpatient. It is partly on the appendix. We'll give you some of the information around that, but there's some other technical parameters that are in the guide that we can pull up and provide. Bianca, can you repeat that beginning part of the question? Was that Jody's
The
question?
data points are quite different for inpatient versus outpatient per the 3 markets. And just wondering if y'all could speak to that or what you think is behind that. I think I'm hard to hear over here, Sue. Repeat.
Amanda, do you want me to take that?
If you could, I heard inpatient, outpatient. I'm sorry.
Yeah. So I can take that, Ingrid. So if you're looking at this slide versus the bubble charts, are you looking at trends? Or are you looking at the cost growth contributions? Which ones are you referring to? Because the answer might be different.
The bubble charts.
The bubble charts. So in that case, when you look at, so it's easier to go through it market by market. So when you look at the commercial growth, so number one, for all 3 of these, hospital inpatient has actually not experienced a lot of growth for all 3 markets. Hospital outpatient has indeed had a lot of growth. And part of that, we've seen that trend when we did the previous analysis as well. And when we think through over the last decade, there's been a lot of push to move procedures out from the inpatient setting to the ambulatory setting. While we cannot be absolutely certain based on just the data from this data call, I think there's enough corroborating data from other analyses that is a significant driver. Now, yes, it is growing up. But the question then for us becomes is if those procedures had remained inpatient, would the cost growth trends have been much higher? And intuitively, one would say yes, but we haven't done that analysis yet. And the different markets and the contribution of these in the different markets, I think speaks more to, especially for Medicare, the population and the underlying conditions that are being served. Although we don't have that level of detail, again, from the data call analysis, but there are other streams of analysis that kind of tell us the story in the same direction.
But the question really is, why does Medicaid look different on this? That they're actually have a decrease in the hospital outpatient.
During the pandemic timeframe, Eileen, we saw a significant dip in the Medicaid overall spending. Again, spending here is directly proportional to utilization. This is 29 to 22 trend. So that's about the only explanation we have for the significant dip in Medicaid. The overall Medicaid growth in this time frame is also very low.
But Vishal, I think maybe the question, let's see if I'm channeling Eileen. I think the question that Eileen is asking is, if the basis for the increase in hospital outpatient spending is shifting from inpatient utilization to outpatient, then it seems like, and I'd love other people's thoughts, then it seems like we would see hospital outpatient driving across all 3 lines of business. And if it's, so this is the classic, right? How much of this is price? How much of this is utilization? It's that classic question.
Yes.
Okay.
And like I said, we don't have a good quantitative way to answer this question directly, but we have corroborating analyses that kind of point in the same direction. In terms of why the performance amongst different markets looks different, we'll take that back. We'll do more analysis to see if we can find out that answer. Likely not from the data that we get on the data call, but maybe some of the other cost driver analyses and other analytic assets we have.
Thank you.
Yeah, and I wonder on the Medicaid piece, because of the way we carve out some capitation and also because of our high cost infants, wouldn't take a lot to, and so I got some ideas on this too. And I don't know if Megan is listening in, but this will be a great area for our staff to dig into and bring back at a future time. I know we got a bunch of hands. I think it was, who was first? Was it Jody? Jody first, then Bianca, then Edwin. Go ahead, Jody.
Thank you. Initially, I was just going to say, I think on that benchmark by carrier, that you do need to look by product, because my quick look at that suggests that those numbers are driven by the proportion of the different products that are being offered by those carriers. And the more Medicaid, the lower they were, the farther they were to the left. And so I think that the product is going to be important on that. I think on this last conversation, I just, since the vast majority of our patients are Medicaid, prior authorizations are just less common. And so I think there are fewer procedures because people are not getting their stuff approved. And that's part of why you're not seeing the same rate of growth in the outpatient. And when we're talking outpatient hospital now, we're saying same day hip replacement, same day knee replacement, same day major abdominal surgery. And some of these costs are then not being captured by the healthcare system. They're being borne by individuals by costs that don't count into the formula. And so I just think that we also need to think about what is the phenomenon that's happening beyond these outpatient, I wouldn't call them procedures, I would call them major surgeries. And the procedures happened a decade ago, but what's happening now is the major surgeries as outpatient. And so that's really driving part of that. Anyway, I need to leave for 15 minutes and then I'll be back. Thank you all.
Jody, thank you for that insight. Again, lots for us to keep noodling on, and for the staff, this is really just rich conversation. Go ahead, Bianca.
Yeah, thank you so much. Really great information. I have lots of questions, so I'm trying to figure out how to kind of focus here because I know we're short on time. So just a couple observations, and one observation, one question. So I did notice that we're sometimes switching between the 1 to 3 years, and I understand the 3 to help kind of normalize what's happening during the pandemic. I do think it's just worth noting that in the breakdown by the different, private health insurance versus Medicare and Medicaid, that this most recent year, it looks like commercial was actually lower than Medicare growth, right? If I read the line graph correctly. So it'd be great to know how other states are around that, if that similar kind of drop in commercial growth also happened in the other states. So it's kind of a comment. I'm just curious. It could be an outlier, but it'd be interesting to know if other states experience that. The other one is I'm not so sure how to interpret Kaiser on both of those as both a provider and a carrier. I mean, I know they're integrated, and it looks like the numbers are basically the same exact numbers in the two. So I'm just wondering, from your perspective, how is there a difference in how something is calculated for Kaiser in the provider versus carrier calculations, or are they basically the same numbers? And it's worth noting, I mean, I think of Kaiser as being very focused on primary care, and I just found it surprising how high up they are in terms of growth. So based on those earlier conversations about primary care and how's that kind of fitting in here, and they're also very outpatient driven, I just find it really interesting to see that they're so high up here. Thanks.
Great input. Edwin, you get the last question, then we're going to move to a break. Go ahead,
Thank
Edwin.
you. To just echo the sentiment, though, there's really nicely prepared, nice analysis, nicely well done. Question, I think there was a comment that I think was warranted in terms of the results, perhaps not fully capturing the dynamics of the pandemic period. And I think with that in mind, I was curious if the analysis team has thought about the extent to which some of these increases reflect care that might have been deferred, or could be catch-up care from the pandemic, as well as whether some of this is from the pandemic itself.
Thank you for that, Edwin. Vishal, any thoughts from either you or Amanda on that?
Yeah, just real quick confirming that, Edwin, we are starting to see that in the data. So we see that spike in 21, kind of recovering from the dip in 2020 during the pandemic. And in 22, we're seeing that spike come down slightly. That's why I said the next couple of years are going to show whether we get somewhat of a yo-yo and a normalizing curve after that, or does it start stabilizing around a certain growth rate. Of course, healthcare policy has a lot to do with that. This is not a system that operates independent of the other drivers. So yeah, more to come. But you're right on. I mean, it's something to watch for. Yes.
Well,
Thank you.
Vishal and Amanda and the team here in the room, this has been a fabulous presentation, great baseline data. I still have to just call everybody's attention to slide 14. Our total health expenditures since 2017 is almost 22%, and we still have real, challenges ahead, knowing that we're using $2 billion more in the hospital financing, and knowing kind of some of that utilization is still playing out. So it's going to be very interesting to see how our next year data comes out. But what a great start. I let us run over 5 minutes. So because this is a longer meeting, we are going to take a 15-minute break, and the bathrooms are right out here. A 5-minute break. 5-minute break. 5-minute break. 5-minute break. You're watching me today. It's good. And then we'll get back in 5 minutes at 2:40. So everybody do a stand break, get some water. Thank you, Vishal, Amanda, and team.
Thank you.
I'm not enjoying.
Ask. Right.
Yeah.
I
always try to get off mine off.
Right.
Not beyond our taste.
No problem. I'm gonna run.
Yeah, that's the other thing. Absolutely. And so what might look
Great. To those of you that are listening in, and we're going to open up the camera here. We are called back to order, and I'd like to introduce our first panel to share the results from Washington Healthcare Affordability Survey. We're really pleased to welcome our three panelists with us today. Emily Bryce, who's our co-executive director of the Advocacy Northwest Health Law Advocates, Jim Freeberg. Did I get that right? You guys bear with me. Okay. Jim Freeberg with the Patient Coalition of Washington, and Sam Hadson-Beller. Did I say that right, Sam? Yep. Baylor, Senior Policy Associate, the Economic Opportunity Institute. So thank you three so much for being with us today. And we're going to turn this over to you. And just please try to yell to the ceiling. It's kind of like a divine thing where we're speaking loudly to the ceiling.
Okay. Thank you. Good afternoon, Chair Birch and members of the board. I am Emily Bryce of Northwest Health Law Advocates, so pleased to be joined here by Sam Hadson-Beller and Jim Freeberg. And each of our organizations has been working to expand access to affordable healthcare for Washingtonians for some time. And in recent years, we have worked together on an effort that we call Fair Health Prices Washington, which unites patients, frontline healthcare workers, and businesses, all of whom are struggling with the costs of high healthcare prices in Washington, to work towards solutions to that problem that could drive down the cost of care. And given this mission, we have really been supporting and strongly supporting the board's work. Thank you so much, and thank you to the team who did that excellent data analysis earlier today. We appreciate the chance to share the patient perspective as you review the cost board's first benchmark performance analysis. And as we have been reflecting on that data and had a chance to sit with it, we've been observing a few things. First, we need to be clear that Washington's health entities in the aggregate as a whole failed to reach our target for 2022. We were close, but we did fail. And overall per member spending exceeded the gross benchmark as we were talking about in 2022. And that should strike us as a warning signal, because let's put ourselves back to where we were in 2022. It was the waning days of COVID, of the pandemic. People were sitting home, were quarantined, were not seeking healthcare services that we didn't need to be getting then. And so one would really expect to see slow growth during that period. And so the fact that we didn't quite meet our goal should strike us as a problem. Second, and I heard this from all the board members, but just to drive it home, we really need to contextualize that growth with a patient-centered lens. The difference between 3.6% and 3.2%, it doesn't seem like much if we're just thinking, math. But from a consumer's perspective, remember that what we actually want to see is 0% growth, because we started from an unaffordable place in the first place. Our current healthcare costs are untenable even before we started this cost growth benchmark process. So when I think about 3.2%, I actually think that's a generous benchmark, because when we look at wage growth from that same period for 2022, wage growth was 2% during that time, right? So what's the difference? Where's that coming from? It's coming out of all of our pockets. Third, we need to remember how pressing these issues are for Washingtonians, and we're going to get to that in a moment. So thank you for bearing with me. But we're looking at 2022 data today, and we have to realize that, of course, the situation has gotten worse for Washingtonians in the last 2 years. I do not have to tell this group that in the last 2 years, 3 years, going into 3 years now, we've been looking at almost double-digit premium increases in the individual and small group market. Similar trends elsewhere. That's on top of rising deductibles, copays, coinsurance. It's all going up and up and up since 2022. And it's true, we have seen some data recently that shows that Washington is doing pretty well compared to other states in some respects, right? If we celebrate that, that's really important. But our measure is the United States as a whole, which, as we all know in this room, has highest spending and some of the poorest outcomes among developed countries. So there's not that much to celebrate there. So every year that we wait and we continue to analyze the data without too much action, and it is important to analyze that data. But I'm also excited that the cost board has been thinking about policy measures, because it is an acute crisis. We're going to hear that in this presentation, and it's only going to become worse as we hit what is going to be a very rough budget period. Everybody in this room knows that. the kind of patchwork of things that we have put in place to cover over some of the worst edges of this affordability crisis are going to be in trouble, and that will lay this problem bare in a new way. And then finally, I think everybody knows this in this room, but we collectively own the issue, and include all of us here. In later panels today, you may hear from folks who say, "Oh, well, the problem is here or the problem is there," and that can't be our attitude, right? We really have to be thinking about how every component of the healthcare system is contributing to these challenges and how we can each be reversing the trend and taking an introspective look at that. So enough of me. Let's get to what Washingtons are telling us directly. And if we go into the next slide, we'll get to that. So as I mentioned, we really want to make sure that we're reviewing the aggregate spending benchmark data in conjunction with other measures that tell us how Washingtonians are doing directly in our healthcare system. And unlike many states, Washington doesn't yet have an underinsurance survey. And what I mean by an underinsurance survey is a survey that tells us for Washingtonians that do have insurance, whether they can afford that insurance, afford to use that insurance. And of course, the cost board was charged in House Bill 1508 with developing an underinsurance survey and an employer survey. And I hope that is in the works and continues to be in the works. But in the meantime, we're working with what we have. And so consumers and patients have taken it upon ourselves and our organizations to try to gather as much information as we can about affordability issues. And in 2024, the Fair Health Crisis team worked with our national partner, a nonprofit United States of Care, and a survey firm called Digital Research Incorporated to survey over 1,000 Washingtonians over a period of 2 weeks this past June. And this survey follows up on a similar survey that we did together with Yale Farm Institute in 2022. They're not identical surveys, so they shouldn't be taken and compared longitudinally because they just work slightly different methodologically and questions-wise. But together they give us a bit of a sense of how Washingtonians are doing. So I'm going to, if I can, if we have him on the phone, turn it over to our colleague, Travers Burnett from the survey firm DRI, who's briefly going to review the methodology just so folks have a sense of that. And then we'll go to Sam to share the findings and some reflections from Jim. Trav, are you there? Yeah. Travers Burnett. And it's okay if I can.
How's this? Am I in now?
Go ahead, Travers. You are.
Okay, great. Thank you, Emily, and good afternoon, everyone. Again, my name is Trav Burnett, and I'm representing Digital Research, an independent public opinion polling firm founded in 1992. We conduct surveys and focus groups across the country for a variety of clients in the public and private sectors. We were especially pleased to be involved with this study, and I really appreciate the opportunity to be with you today. As Emily said, I'll speak a bit about how we conducted the study, and then I'll stick around for the duration of the discussion and answer any methodology questions that might happen to come up. Now, some of the methodology information is on screen here, but there's also more detail in the appendix of the report that we're going through now. And as Emily mentioned, the survey was conducted online between June 13th and June 27th of this year. A total of 1,006 Washingtonians took part in the survey, which the average participant completed in about 15 minutes. And I'll go ahead at this point, start my camera. There I am. All participants were registered to vote in Washington and said they were extremely or very likely to cast a ballot in last month's general election. And the findings the team will talk about today are representative of the state's population in terms of age, gender, race and ethnicity, level of education, and even political party affiliation. And I can also say that we made sure we surveyed an adequate number of rural Washingtonians to ensure that their views and experiences with healthcare were adequately represented and balanced against those who live in urban or suburban parts of the state. So now I'll hand it over to Sam to start our review of the findings, but again, I'll continue to be here in case anyone has any methodology questions during the discussion.
Thank you, Trav. Thanks to Emily. Thank you, Director Birch, and to the board for having us. We really appreciate it, and just want to underscore, really appreciate all of your work to work on healthcare affordability. Why we formed Fair Health Crisis. Very pleased to be here. It's my first time in this building, so happy to be here. As Emily said, I'm Sam Patzenbuehler. I work at the Economic Opportunity Institute, which is a progressive policy think tank working to make Washington a national model of fairness, care, and opportunity and healthcare affordability. Has been one of our top priorities for the last 25 years. So let's get into the data. Okay, speak up. Okay, got it. Speak to the ceiling. Go to the next slide. And there we go. So yeah, let's get into it. It won't be a surprise that the survey results are quite alarming. It just kind of underscores what Michelle and Amanda were going over before, that people in Washington are really worried about their healthcare, worried about going to the doctor, worried about going to the hospital, incurring debt and delaying care because of high healthcare costs. You can see here on this slide that 63% of people surveyed were worried about their current healthcare costs, and a whopping 88% were worried about affording costs in the future. Next slide. So we asked people what burdens they had experienced in the past year due to cost alone. 57% said that in the past year they had avoided seeking medical treatment or changed the use of their prescription drugs because of cost. You can see the impacts on the slide. It's a bit small, but I'll just highlight a few. That 36% delayed or skipped going to the dentist, a third skipped or delayed going to the doctor, healthcare provider, and then a fifth of people skipped a recommended treatment. So, a third or a fifth of people not getting the care they need, it's really striking. Next slide. So while the survey showed that a majority of Washingtonians are struggling with affordability, there are disparities that we want to highlight here. Not all communities are facing this in the same way. You can see here on the slide in red that Hispanic and Latino folks, as well as African Americans, that 75% of those communities are reported negative impacts due to cost. That's compared to 57% of white respondents, which I'll note obviously is still far higher than we would like. Impacts were also quite higher for small business owners and people with disabilities at 75% and 65% likely, respectively, to report having to take steps to manage costs. Next slide. So we all know that costs are high, right? But part of what we wanted to get at with the study is kind of the survival math. That's a term I use for when you have to, figure out, do I have to spend, cut back on my housing or food or heat bill in order to cover healthcare costs. So what we found is that 2 out of 3 Washingtonians, so 65%, experienced one of the impacts on this slide. We asked about financial, emotional, medical, debt, and credit impacts. Of people reporting impacts, 55% said that they experienced some kind of financial impact, like struggling to pay for basic necessities like food or heat. 45% said that they experienced some kind of emotional or medical impact, like losing sleep or being afraid to change jobs because of fear of losing healthcare. 44% experienced some kind of debt, like having to go on a payment plan or borrow money from family or friends. And more than 3 had their credit impacted, like getting a lower credit score or having to, or being taken to court for a medical bill. Medical debt. I know the board has hosted presenters on this topic and has taken a look at this. And that also it's very hard to get state level data on medical debt. So we wanted to make sure to ask about medical debt in our survey. This was generally consistent across income levels, that 1 out of 3 Washingtonians are living at the time of the survey with some form of medical debt in a household. This survey, I wanted to note the definition of medical debt is a little bit different than some other surveys. I know that the Urban Institute definition is just medical bills that have been sent to collections, but in our survey, we defined it more broadly as anyone needing to go on a payment plan or rack up credit card or other debt or take out loans to cover healthcare costs. So this really gives us kind of a more comprehensive picture of medical debt in our state. So, so I said 1 out of every 3 living with medical debt, and we also learned that 63% of people said that they would struggle to pay or could not pay for medical bill. Again, there's disparities as with other categories like small business owners, by disability and race. So the full survey, we really recommend taking a look at it. It has a lot of rich data and different demographic groups. Next slide, please. We wanted to take a look also at where medical debt is coming from, and this dovetails with the earlier presentation that hospital source is the primary source, or the largest source of medical debt at 44%. So that's far outweighing other sources. And this isn't on the slide, but since we're talking about hospital visits, I also wanted to mention that only 36% of people who responded to the survey said that they had been told about hospital financial assistance. So really underscoring the need for us to continue strengthening our implementation of our charity care law. Overall, these hospital costs are really translating to a lot of worry for people. 3 in 4 respondents reported being somewhat or very concerned about paying the out-of-pocket costs for hospital care, with communities of color being particularly likely to be concerned. I also know the board has taken a look at facility fees and has made a recommendation to limit facility fees. So we made sure to ask about these. We know a lot of people are experiencing being billed a facility fee. We defined this in the survey as any additional fee. It's a facility fee can be tacked on to your bill when you're seen at a hospital or a hospital facility, even if it's not on the campus of a hospital. And these are in addition to any medical services you've received. They can be upwards of $1,000 per visit and are sometimes not covered by your insurance. We learned that 4 out of 10 respondents had received a facility fee at some point. Next slide. So obviously we want to ask a lot about affordability, but in addition to that, we wanted to give just a few data points to give a fuller picture of what people are experiencing when it comes to health insurance. So we wanted to also ask about people's issues understanding, using, and accessing their health insurance in the past 2 years. And we learned that despite a high rate of coverage, which is something we are very proud of in our state and should be, despite that high rate of coverage, 3 in 4 people are facing any of the challenges listed here on the slide. You'll see that for people who had difficulty understanding their coverage, of those who had any difficulty with their insurance, 54% had trouble understanding their coverage, including what providers are in network. Also, half had difficulty accessing their insurance, like finding providers. And these data are also broken down by demographic. Okay. And lastly, we just really wanted to get a sense for what appetite there is for making change, and the overwhelming response across race, economic status, geographic location, political party, overall was yes, Washingtonians are really supportive of elected officials taking action to where the 87% of people either somewhat or strongly agree that electeds need to take action on it. Notably, 61% of people said that they don't believe that private industry alone can address and regulate costs. So that was actually very similar across political parties. Participants also showed strong support for solutions like addressing health system consolidation, lowering prescription drug prices, and making insurance more affordable. So thank you so much, and I will pass it to Jim, who's going to tell us more about participant experience in their own words. We also have a question.
Go ahead with your question. I explained for my best.
Just having a little difficulty hearing.
Okay, thank you, Margaret. We will make certain to turn up the volume. Outside voices, everybody.
Okay, Jim Reber with the Patient Coalition of Washington. I am going to share with you a few quotes from folks that responded to the survey in their own words. If this was in response to the question, then I hope everybody in the room asks everybody they know as often as possible, because I think it really illuminates what we all should focus on. And it's very simple. You can change anything in our healthcare system. What would that be? And I think back to a woman I met in Wenatchee a year ago. I was talking to her about this, and she shared her story. She's a small businesswoman. She has the job of her dreams. But her response to the affordability crisis is to have health insurance every other year. She takes a chance and knows when she has health insurance, she's going to go see the doctor. When it's not her year to have health insurance, she just hopes that everything's going to be okay. And that just frightened me, but it really spoke to what people are dealing with every day in our state because of this issue. So we'll go to the next slide, and I'm going to let folks read these quotes on their own. We'll try and rush through it to allow some time for conversation. These are open-ended questions. We do have some demographic information up here, but I want it to be known that the sentiment is universal, regardless of political affiliation, urban, rural, age, ethnic, race identity, that we simply pay too much for healthcare in this year, and the problem gets worse and worse. Our expenses go up, and unfortunately, as you saw in the data that Sam shared, our access gets worse, right? There's especially in our state of primary care shortage, where you just can't find a doctor, right? That we're paying more and we're getting less, and that's what people are really upset about. Tragically, this resulted, I think, in the outright murder of a health insurance executive recently. It is absolutely unacceptable. But the response to that should not be a surprise for anybody. That Americans share this massive frustration of how poor we're doing on this issue. And the outpouring on social media was people's immediate reactions to this terrible thing, but their own personal experiences with how the healthcare system is failing. So I hope that's all something that we can take away as the reason, of course, for this board to exist, but for us all to be united around concrete action. So as we go to the last few slides here around discussion and some reflection, we have some ideas for future study. We mentioned the studies that the cost boards can do in the future, and we really hope those can be done rigorously year after year to show whether or not we're making a real difference in people's lives. We know we need to broaden the sample, and we need to reach out for samples in languages beyond English. This was done by a nonprofit with limited resources. We really need to capture everyone in our state. And so we hope that you'll consider these as you do your work in the year ahead. Next slide, too, around discussion. Happy to have, if there are questions, entertain for a little bit of conversation. Again, a starting place, if you're interested, for how the board can build on this data and think about this larger context we heard this morning and how these costs are. So,
thank you to the three of you. We probably have time for just one quick question, and then we'll start our next panel, but very important and certainly jives with a lot of the medical data presentations that the board heard you all very involved as well. So, board members.
Hi, Ceiling. Panel, thank you. There's just such a, I don't know if this is the right word, but cacophony, like a disconnect between the benchmark and that, you know, the proximity to it versus what we're seeing on the ground with affordability. And we are feeling that in a big way, as you know, at the exchange. And the prediction that 70,000 people, up to that amount, we're gonna do more projections now, but a lot, tens of thousands of people in our state could lose coverage if the enhanced federal tax credits go away or when they go away. So I appreciate you making sure that we're seeing these things in tandem. And how do you explain that disconnect? You spoke to it at the beginning, Emily, but any further thoughts?
Well, I think the benchmark is an aggregate measure, right? And so what you're seeing here is years of compounding increases, decades of compounding increases, right? And so we started our work benchmark year. And anything that we can do is really just kind of trying to keep the lid on a pot that was boiling when we started. And what is
I mean, I think part of it also is just the shift on to patients and workers, that as, you know, costs go up, as premiums go up, we're seeing those costs really land on people. And, you know, we heard time and again, small business owners really struggling to cover costs or not being able to cover health insurance for their employees or themselves. And so you know, there's more and more profit being made, but patients are being charged more and more. So we're very grateful for the work, but yeah, it's, as Emily said, I think we started here, so.
And we also know that so much of healthcare is not paid for by the individual, right? It's opportunity costs in the sense that if your employer gives you health insurance, you're not getting that in a wage, right? But you don't really know that in the sense that you look at your paycheck, you look at your health insurance premium, it doesn't show the employee or employer contribution, what you're not getting, right, that you should be getting. And then Medicare, right, we're only paying taxes for that, so you don't see that now these taxes keep going up. So consumers are hidden, I think, even by these costs when you look at just those numbers, but they have all these experiences that they can point to of a denial or a provider that they can't get into. They're the direct symptoms of this big affordability issue, right? So people see it very differently.
All really important points. Great question, Ingrid. Thank you to the three of you for your ongoing work and partnership as we pushing this very large boulder uphill. And we are not going to give up. So thank you. Next, I'd like to invite forward our second panel to share perspective from the Washington providers and carriers. Welcome our three presenters. We've got Don Anderson, I think, on virtually, correct, is the VP of reimbursement at Providence. Got Jeff Shepard, he's known to us, our director of policy at the Washington State Medical Association, and comes to virtually every board meeting. So welcome again, Jeff. And then Jennifer Ziegler, the contract lobbyist for the Association of Washington Healthcare Plans. So thank you to the three of you. Who's going to start on?
Right. Good afternoon. This is Don Anderson. Can you hear me okay?
We sure can, Don.
Great. Thank you. I just have a few comments, primarily focused on the reporting that was issued recently as far as the data for our particular organization. Again, my name is Don Anderson. I'm the VP of reimbursement for Providence, which includes Providence, Swedish, and Cadillac in Washington. On behalf of Providence, I would like to say thank you for the opportunity to speak here today. And we're talking specifically about the cost growth benchmark reports that were published in September. Providence's background is that we are a nonprofit, not-for-profit healthcare system committed to providing healthcare for the needs of the communities that we serve, especially for those who are poor and vulnerable. As Washington's longest serving healthcare system, Providence in Washington includes 15 hospitals, physician clinics, senior services, supportive housing, hospice, and home health programs, care centers, and diverse community services. We appreciate the goals of the board in terms of examining cost growth within healthcare, and we are here today to discuss the provider report specifically and the challenges and opportunities we see for the future as we use these reports to learn together, and our comments will echo the letter that we submitted in response to our provider report in October of this year. First, I'd like to talk a little bit about the data aggregation and the data validation process. We support the goal to examine cost and to understand how the data is coming together so that we can understand those results. With that, it would be important to also understand the key drivers of those results and be able to respond to the reports with information or develop action plans within our own organization to address cost growth if opportunities can be identified. Our concern currently is with the way the data is currently being provided. Because it is aggregated at the provider entity level, it does not really allow us to do those things that I just mentioned. For example, Providence received one report with basically one set of numbers for all of our claims data in the state of Washington. Given that our footprint includes 15 hospitals and many clinics, data aggregated at this level does not really provide actual information to track and analyze costs, understand whether there are outliers that need to be addressed or other actions to take to contribute to the overall goal of managing healthcare costs. Without more detailed or granular data, we cannot leverage this information in a truly meaningful way to address those key drivers that influence the data being used by the board. Based on the level of aggregation of the data in this report, it simply is not possible to validate the data on our end as a provider. The inability to validate the data is concerning because we're unable to ensure that it is accurate and reliable. And if we cannot confirm the integrity of the data presented, we risk flawed or incomplete data being presented on our behalf. While we understand the board has not directly collected the detailed data from carriers or payers, as an example, we do request that we have the opportunity to revisit that process and possibly obtain that detailed data from the payers, providing reports to providers that include data provided from the payers to the board by a hospital or legal entity, such as a tax identification number. And why this is important is just to give you an example. We received a direct request from the board to provide our tax ID numbers because I think there were some challenges in being able to determine the payments that would be attributable to Providence Health. So we provided a list of all of our various tax ID numbers, and there are numerous ones that Providence has because of our complex legal structure. So we have provided that information to the board, and the payers have that information as well. It does seem that, it would be possible to be able to get that data from the carriers directly and have that be a part of the validation process so that we do truly have an opportunity to review and verify the data. We think the process could be beneficial being centralized. The guidance that we received were to reach out to the payers individually, but that would be a fairly inefficient process. If we could build this into the process of gathering the data, then the validation part of that could be much more streamlined and would save a lot of effort. If the data being provided by an identification number such as a tax ID number is not possible, we would love to have the opportunity to work with the board to find another path to getting data that is provided at the entity level in some way. We believe that will be crucial to being a good partner to the board and being able to review that data across the facilities within our system. Receiving the data at that level will truly help us with understanding what might be in the data, whether there are outliers or trends in the data that could be meaningful to the board in using it to assess what's happening within the payer data that you all are evaluating. This also will allow us to understand and or validate the attribution methodology used so that we can truly identify the patients that are being seen in our facilities and more appropriately evaluate the data. I appreciate some of the comments that were made earlier about Medicare. One of the things that I wanted to comment on Medicare is that in terms of the payment data that you are looking at from Medicare, especially in the world of fee-for-service, there are some changes within the payment system that I think have the opportunity to impact the payment data we're looking at fairly significantly. One of those is the wage index factor. In the Medicare prospective payment systems, the wage index factor drives approximately 68% of the Medicare inpatient payment and 60% of the outpatient Medicare payment. And this factor has the potential to drive differences in Medicare payment rates across hospitals and years, and can have a fairly significant impact on the cost growth data that you are now that's being analyzed compared to the benchmark. If a wage index factor changes significantly for a particular hospital or a geographic area, it has the potential to swing the Medicare payments, including Medicare Advantage payments, for contracts where they're based on the same Medicare payment methodology, and it could impact the payment data significantly up or down. We are anticipating that there will be some volatility in the Medicare payment data in the coming years due to some changes CMS has made in the definition of how they calculate the wage index factor. For example, in 2024, CMS finalized a major change to how they calculate the wage index factor for rural areas in all of our states across the country. This volatility could result in some unpredictable increases or decreases in Medicare payments. This is a well-known factor within kind of the reimbursement world, if you will, but we have some concerns in Providence as well that we could see that volatility in the coming years, and it could result in some variability in the payment data in the coming years that will be analyzed. Hopefully, we could come up with a way to normalize that data so that we can weed that volatility out of the analysis on a year-to-year basis. But I do believe that's something that could have a significant impact based on some of the information that had been provided previously in the meeting today as far as how much of the cost driver is related to Medicare.
Don, we probably only have about another 4 minutes or so, and I know your co-presenters need to make some comments. Do you want to go ahead and just kind of wrap us up with your comments?
Sure. Thank you. I guess the last thing I would say is from the standpoint of collaboration, I believe we have an opportunity to improve collaboration. One of the things that we've requested is an opportunity to review our own data with the board and understand the importance of the factors and the data going into that report and understand truly how it's being utilized. Again, going back to the validation piece, we would really like to be able to understand what is driving those numbers. And with the data at the current level, it's very difficult to do that. We requested an opportunity to review that with the board, and we would hope that we could have that collaboration in the future as well. And I think other providers would benefit from that also. So I apologize for going over time. Thank you for the opportunity to provide comments and appreciate the time today.
And Don, I just want to reiterate that we hear your concerns about data validation, accuracy, wage drivers. We hear you. This is a journey that we're on together, and we certainly appreciate that everybody's involvement in all of our committees. So thank you for that feedback. And I know attribution and all of these things continue to be ongoing conversations. Which of you two wants to go next?
Chair Birch. Good afternoon, everyone. My name is Jeff Shepard, Director of Policy at the Washington State Medical Association, representing 13,000 physicians across the great state. Thanks for the opportunity to participate on the panel today. And congratulations to members of the board and Healthcare Authority staff for achieving this milestone. As was noted, I've been here since the beginning, and you guys have done an awful lot of work. It's something to be commended. We've been an active participant in this work, providing feedback via public comment, written comment, participating on the advisory committees, because our members are acutely aware of the affordability challenges that patients face today that were underscored by the previous panel. And they feel the rising cost of delivering healthcare within their own practices that they themselves struggle to understand. So it's great that we're on this journey. To that end, we want to be constructive partners in lowering costs in a responsible way. And when I say responsible way, I mean with an eye toward minimizing the impact of unintended consequences in terms of patient access to care. We've been meeting with our physician groups that are on the benchmark list to collect their feedback around improvement. And so there's 5 areas that they shared with me, and I'd like to use this opportunity to share them with you all. And some of them were touched on by Dawn, so I'll be brief. As you all know, the Medicare data is incomplete. For one of our members, missing one Medicare Advantage partner, is about 30 to 35% of its total Medicare population, which is a significant distortion. We talked about verifying the accuracy of the reports, and we'd be very happy to work with the Healthcare Authority, insurance carriers, hospitals on a way that's more manageable for everybody. Aggregating data or unbundled at at the TIN level would help with that verification, but also help folks understand where the costs are being driven within their own practice. At times, patient attribution methodology is non-standard based on the hierarchy on page 4, the carrier technical manual, and our members would love to see where the methodology does deviate, sort of what they're using. Is that stopgap. A couple of days ago, Milbank released an issue brief on patient attribution benchmarking context, overuse challenges with attribution in general, and highlights how Connecticut, Oregon, and others have approached this, including reporting at the TIN level. Finally, this was their chief concern, and it was raised by all of our groups. And it's simply about context, not necessarily about the model itself. Our members feel there's important context that should be provided when reporting this information to policymakers and the public. For example, if a patient is assigned to a specific group, because that's where they get most of their healthcare, their primary care, and then that patient is then hospitalized, those hospital costs are attributed to the physician practice. And physician practices don't have any control over those negotiated rates between hospitals and insurance carriers. I asked them what they would like to see in its place. If there's a better methodology, they said there's not. That this is a typical methodology used for value-based payments. But in this context, when using it to publicly report against a benchmark, we would appreciate that context be provided, that not all healthcare costs are within the control of the physician practice. And HCA has indicated a willingness to improve the reports and ensure the accuracy, make them more actionable, and we stand by, ready to assist in the process. My final note here is I agree with the previous panel. I think we're going to see provider groups struggle to meet the benchmark in the out years. One, there's a lot of market distortions created by the pandemic, but one of them is inflation, right? Some of these contracts where we're looking at the rates for 2022 were negotiated in 2019, 2020. They're on a 2 or 3 year cycle. They were negotiated during a different world. So physician practices can't pass the cost on to their consumers, so to speak. They have to negotiate those rates higher. Those negotiations are taking place right now to cover the cost of care. So lots of distortions to work through. Continue on this journey with you. We'll continue to be here. Please consider us a resource.
Thank you so much for those comments.
Great. Thank you, Chair Birch. My name is Jennifer Ziegler. I'm a contract lobbyist for the Association of Washington Healthcare Plans. We represent 12 carriers covering about 6 million Washingtonians across all markets in the state. I want to start just by saying a big thank you to the Healthcare Authority staff for working with us through the multiple data calls in this process. I think our folks have indicated to me that we felt like there were lessons learned as we went through each step of the process. And so we look forward to, continuing to refine those efforts. We'll delve into the data just as you all are. I think we've got 4 quick takeaways at a high level. So the first is, we saw it in your conversation already this afternoon, right? The context matters. And so as you all, I think we have some of the same questions about some of the, what's driving some of the outpatient versus inpatient categories, what's actually in that non-claims category. So we're going to be interested to delve into that a little bit more to see what lessons learned can come from that additional information. The second thing that we would just say is, to underscore Jeff's point, there are costs that are beyond our control for each of us who are part of the system. And I don't say that to say that doesn't mean we should just all throw up our hands or point at each other. I say it to say that from our perspective, we think that means that whenever you all are sharing this information with policymakers, we hope that you'll remind them that this is a comprehensive system and there are disconnects sometimes when you make policy decisions in a vacuum. And so the whole set of this data is really important from our perspective. The third thing that I want to be sure to say, and I hope doesn't get lost as people are reviewing this information, is we were really pleased to see that a lot of the cost driver information in the report is consistent with what the plans are seeing. So in particular, more and more, we continue to have greater growing concerns about the cost of prescription drugs. So seeing what a big presence that was in this information was really helpful. And then the final thing I just say is I just want to take the opportunity to thank you for the policy recommendations and the annual report. In particular, we intend to pursue legislation again this year related to facility fees. So we really appreciate you taking an integrated approach, not just the data, but then also the policy solutions.
Thank you all for your insights. John, you can't see us, but I'm telling you all that we are we're not surprised, but we are sharing and rolling this information, into kind of our future thinking, and certainly looking working on all areas with your partnership. And it's going to be an ongoing challenge to keep engaged and keep working on this. I'd like to invite now our last panel to share their perspective from the Washington Business and Labor representatives, and we're pleased to welcome our three presenters. We have Zenobia Harris, the CEO of Kent Chamber of Commerce. I think she's online. Have her online yet? We have Patrick Connor, ICM, CEO of our Washington National Federation of Independent Business. And we have Christina Johnson, our Managing Director of Health Benefits Trust, SEIU 775, online. Have her online. So we know we have two of our three panelists. Patrick, I'm going to turn it over to you since you're in the hot seat. Novia, if you are on, if you could unmute, or what's the last four, we'll unmute her. We're looking to see if Zenovia's unidentified phone number.
I can allow to talk, but I don't know who it is.
Why don't you go ahead and open it? We'll just see if that's Zenobia. And in the meantime, do we have Christina? Are you unmuted?
I am here, yes.
Great. And Zenobia, is that you? Anybody texting us? Might not have our third panelist. You are on. If you want to text one of our phones too, Zenobia, that would be helpful. The number we should have you call is 360-878-0129. Okay, Patrick, take it away and we'll watch for any communications from her.
Thank you, Director Birch. I'm Patrick Connor, Washington State Director for NFIB, the National Federation of Independent Business. For the few of you in the room who may not be familiar with this, NFIB is a national association representing small and independent businesses exclusively. We've been doing this for more than 65 years. Our program also includes a rather robust research center. And in fact, every 4 years, we release our problems and priorities report, which I would say summarizes, but lists about 100 of the top priorities and problems facing small businesses nationwide. And for the 38th year in a row, the top concern for small business remains the cost of health insurance.
I'm sorry, they can't hear. I think they're.
I'll do my best. Sorry, I feel like I'm yelling at.
You're gonna have to yell at
that. Thanks.
You wanted to.
I was gonna say.
Now's your chance.
I'm sure as many of you know, the lack of affordable health insurance options is a problem nationwide. It's also a problem in Washington State. For many, many years, far too many, we have had an anemic small group market and really no obvious solutions in sight. One of the few sort of redeeming factors of healthcare or health insurance options in our state is that we have had for a long time a robust association health plan market, which has allowed small businesses to band together to negotiate for health insurance policies. And since 2010 or so have been more closely focused though in bona fide industry groups, which has led to somewhat smaller pools and a somewhat weaker bargaining position, but at least the opportunity to bargain with carriers for better rates compared to most of my members who are on their own trying to navigate the small group market if they are able to, or they and their workers are trying to find coverage through the exchange or in what's left of the private individual market. That continues to be less successful than we would hope. I've said it already. sure many of you know that small businesses are only about 40%, of small businesses are able to offer an employer-sponsored health plan. And that situation is not getting any better. One only has to read the annual press releases from the Office of the Insurance Commissioner to see that we basically experience year-over-year rate increases in the small group and in the individual markets, which provides no relief for those employers who are attempting to do the right thing, provide for their workers through offering health insurance as part of a robust benefit package. So there is, I think, a lot of work to be done in general on many fronts to provide more opportunities for employers to provide either policies themselves or find a way to better provide for alternative approaches that allow their workers access to quality health insurance plans. In terms of the cost board and our view of that, we will repeat our often given plea. Don't forget about transparency. Consumers, small business owners, individuals alike need better access to quality data that allows us to compare plans and providers. We need better tools to equip us to make better informed decisions about where to spend our precious healthcare dollars. And we need to be able not only to afford the policy, but to afford the costs that go along when you try to use that policy. Co-payments, co-insurance, other cost-sharing mechanisms are becoming more and more burdensome on policyholders. And that becomes more and more frustrating when you see statistics out there, like a third of a certain national carrier's claims last year were flat denied. We find it troubling to see that so-called nonprofit carriers, the two largest in our state, have for more than a decade now amassed and maintained more than $1 billion in unrestricted surplus, and that's based on a 15% medical loss ratio. Our organization supported OIC request legislation many, many years ago, asking for the authority to review that unrestricted surplus and consider it in the rate making process. It's unfortunate that that tool has not been used. I think it might be helpful for the cost board to help to monitor the size of those unrestricted surpluses and perhaps get some better information as to why they continue to grow and are not being used for any of the myriad types of reasons that we were told they were needed, such as compliance with the ACA, the movement to medical health records, surviving a catastrophe. Well, if COVID hasn't hit all of those marks, I'm not sure what will, and yet we still have carriers with a 15% medical loss ratio are sitting on more than $1 billion of a purchaser of small business and individual market consumers' dollars, basically tucked under a mattress or, invested in a way that they continue to reap the benefit, but we're not seeing that in premium reductions or in offsetting the cost of premiums. A couple of other recommendations that we would suggest, just as small employers have been able to band together to some extent for association plans, we have watched small provider groups being forced to find ways to band together either through consolidation, or unfortunately, we're seeing more and more acquisitions of small providers into larger systems, which is the only thing they're able to do in order to get the kind of reimbursements they need in order to maintain their practices. But as we're seeing many of these small providers gobbled up by larger entities, we're seeing fewer choices, fewer providers overall in a number of our markets, particularly in our rural areas. So having some way to better monitor the number of providers, specialists in a given community, perhaps by county level data, I think would be an instructive indicator about the health of the market, something that I think is within the purview of the Cost and Transparency Board. To wrap it up. Yes. We appreciate the work that has already been done to try and get a handle on charity care by hospitals. I think a more public indicator of what hospitals are providing, what level of charity care, and more importantly, how does that quantity of care compare to the tax benefit that those nonprofits, medical systems are receiving. So we ought to have a better sense of whether those tax-free dollars are being used appropriately to provide for those who are unable to afford care otherwise. And finally, I know this is a long shot, but We need to continue to do better to try and unlock the black box of pharmacy benefit managers. It's easy to complain about the cost of pharmaceuticals. As somebody who myself now is a lifelong pharmaceutical utilizer, I understand firsthand that challenge, but it is even more frustrating to know that there's a third party out there, and oftentimes created by or controlled by insurance companies or provider groups, and where those rebates and other dollars between the manufacturer and PBM go, again, we don't believe are adequately traveling down to the individual health insurance subscriber or to employers who are providing coverage for their workers. And I'm sorry if I've run over time, but I thank you for your patience and the opportunity to share these comments with you.
Thank you so much, Patrick. Christina, I'm going to turn to you and I'm going to ask staff, do we have anything from Zenobia? I'm not getting anything this either. Okay, I have nothing. So Christina, if you'll just spend a few minutes and then we'll wrap up this panel and open it up to public comment. So if you're waiting for public comment, please be patient while we get to our last presenter. Go ahead, Christina.
Thank you. Good afternoon, members of the board. My name is Christina Johansson. I use she, her pronouns, and I'm the managing director of SEIU 775 Benefits Group's Health Benefits Trust. For just some context here, the Health Benefits Trust is a multi-employer Taft-Hartley trust that provides health, wellness, and safety benefits to Washington caregivers. The trust is governed by a labor management partnership with a board of trustees. We provide benefits coverage to more than 26,000 caregivers and 3,500 kids here in Washington. Our caregiver population provides home health services to Washington's Medicaid population. And notably, our population is older and more diverse than the average Washington worker. Our comprehensive health coverage includes medical, dental, vision, prescription, and hearing coverage. And recognizing that caregivers' incomes are lower than the average Washington worker, our health plan is intentionally designed to minimize out-of-pocket costs for caregivers to maintain our population's access to healthcare. I'll also flag that many people come to the caregiving field with limited access to consistent or affordable prior health coverage, perhaps similar to, what Patrick was flagging there. As a result, we see high rates of chronic conditions, and this claims experience creates a unique plan purchasing landscape and underscores the importance of cost transparency. We leverage the limited carrier cost data that we have available to us to identify cost drivers within our population and design benefit structures that encourage engagement with high quality and cost-effective care pathways. Rising healthcare, I know this is not going to be a surprise to anybody, but rising healthcare costs are an ongoing challenge to providing high quality, affordable coverage. And costs directly influence our ability to support healthy communities. A few areas that I'll just, flag similar to, other presenters here. We are seeing large cost variances, as you all are looking at the data, we see large cost variances in the per member per month charges in urban versus rural settings. Our rural settings are significantly higher. We have a distinct lack of visibility in carrier per unit costs for prescription and medical services. We're often made aware of issues when providers are contemplating leaving carrier networks during negotiation cycles. However, we don't hear how bargaining outcomes may impact per unit costs. And we also, I was smiling when Patrick flagged the prescription pricing. We have almost no prescription pricing transparency from our Washington managed care plans. With those flags, I'll try to keep this brief, and I'll just thank you all for the opportunity to weigh in on this pressing issue. We appreciate the board's continued work to monitor the healthcare ecosystem and work to make costs visible to health plan purchasers. Thank you.
Thank you so much, Christina. I'm looking at staff and I don't think we have any movement for Zenobia. So last chance, Zenobia, if you are online in the room. So thank you both for providing that perspective. I want to thank all of our panelists today, and we really appreciate the ongoing conversation that we're going to continue to have about all your input as we keep moving this forward. I want to open us up now to members of the public. I believe we have 3 that have signed up. And staff, if you will assist me, I remind you that we, members of the public, that we allow individuals to provide public comments before the meeting and my watch is talking to me, and we will set a timer. So we would like, first off, if you haven't signed up, if you could go online, because I'm not seeing anybody here in the room that is signed up for public comment. If you are called upon, please state your name and affiliation, if any, before you speak. And staff will unmute you as we call on you. I think we're okay today to do 2 minutes per public commenter. And I remind also those that don't like to speak that we take written comments all the time and pass those on to board members in their board packets, as well as receiving them anytime throughout the entire month. So Kaylee, let's see. Would you please start with the names of individuals, if any, who have signed up to provide comments?
Yes, we're going to start with Kelsey Wolfcole and then go on to Krista Abel.
Great. Go ahead, Kelsey.
Hello. Hi, Chair Birch and members of the board. My name is Kelsey Wolfcole. I'm State Advocacy Manager with United States of Care. We are a nonprofit working in states across the country to support advocates and policymakers to develop solutions that ensure access to quality and affordable health care. Today, I want to both commend the board's efforts to address the rising cost of healthcare and also share some recommendations based on our experience kind of working across states. So Washington continues to lead the effort to make healthcare more affordable, continually adapting innovative approaches to curb cost growth, often through the work of this board. Despite this, we know that the amount of money people spend in Washington on healthcare is still too high, as shared by all of the speakers today, the polling results that we've supported, everyone here. So Washington's healthcare cost growth is unfortunately not unique. We continue to see states across the nation grappling with the impact of soaring spending, which is growing faster than inflation and wages. Unfortunately, the spending growth does not mean people are getting better care. In fact, a recent report just came out that people actually rate the quality of their care the lowest it's been in more than 2 decades. So as you consider additional mechanisms to help meet the cost board, reeling in ever-increasing prices, we believe should be a key focus. One of the main drivers of increased prices is consolidation of hospitals and providers. So Washington should consider adopting greater transparency and oversight of healthcare mergers and acquisitions, which is an important step in kind of bending the spending curve. And Washington should also consider focusing on how the financial decision-making of hospitals, the majority of which are nonprofits, directly impact affordability. The Lown Institute has found that the value of nonprofit hospital tax exemptions far outweigh the charity care benefits they provide, which really highlights the need for greater accountability. So I appreciate the opportunity to provide comments. Would be happy to answer any questions you all have today.
Thank you very much. We really appreciate your organization for what it's been doing both here in Washington and then nationally. Kaylee, who do we have next?
Thank you, Kelsey. Next, we have Krista Abel, and then we're going to follow Krista with Claire Olivers.
Good afternoon, everyone, and thank you so much for the opportunity to speak in the meeting today. I did submit comments earlier to Healthcare Authority about concerns that we have with the cost benchmark methodology. And so that's what I wanted to talk about. It's important that the benchmark methodology is accurate and measures cost changes accurately. We have about 16 value-based programs at Virginia Mason Franciscan Health, which, by the way, that's where I'm from. I'm sorry I didn't cover that. Every one of them are risk scored. They're scored for risk and they're separated by insurance. And those are the 2 issues that we have concern over these programs. There's a broad stroke benchmark methodologies that's used that just has age sex adjustment and then just simply combines all the products together. A few examples of changes that wouldn't be considered: for example, a cardiology program gets started in a hospital. A provider group contracts for a new product for Medicaid and they didn't have one before. A COVID situation arises. So there are many situations that these age sex adjustment calculations wouldn't cover. Based on our analysis, this is Common Spirit Health, Medicare Shared Savings Program, and about 250,000 members are in that. age sex adjustment counts for only about 1/3 of the cost variation due to risk. We have concerns about the attribution methodology. There's extreme shortage of primary care physicians in our state and a large number of PPO members that can virtually go anywhere. The attribution methodology relies on unstandardized methods to basically capture those methods and assign them to systems that have never seen those patients. Only about 60% of the medical spend for the patients attributed to our system will actually occur in our system. So it's those are the two concerns we have. We don't think age sex adjustments go far enough, and we very much appreciate that Healthcare Authority responded to our email and is willing to meet with us.
Thank you very much for those comments and also for continuing to participate on our data advisory group. Kaylee, who do we have next?
Next up is Claire Olivers, and then it will be Adam Zarin.
Go ahead, Claire.
Thank you, and good afternoon, Chair Birch and members of the Healthcare Cost Transparency Board. My name is Claire Olivers. I'm the president of the Retired Public Employees Council of Washington. RPEC represents 13,000 public sector retirees statewide. Healthcare affordability is a chief legislative priority for RPEC. Rising healthcare costs are among the leading factors impacting retirement insecurity. Non-Medicare eligible retirees are especially at risk, as many of them do not have the security of an employer-sponsored healthcare plan in retirement. They're not financially prepared for the impact that healthcare and medical expenses have on their limited household incomes. Medicare eligible retirees are affected too. Some RPEC members, for instance, are covered by plans managed by the Public Employees Benefit Board. Despite PEB's excellent work, costs keep going up. One healthcare plan's premium soared by 42% in 1 year's time. In some cases, the premium increases have also been accompanied by reduced benefits, higher out-of-pocket costs, and reduced provider network. Thus, RPEC supports your work. Thank you for working to increase oversight of the mergers and acquisitions, which are limiting healthcare access for seniors across the state. I hear regularly from retirees in rural areas in Eastern Washington about their inability to access in-network providers and specialists. Some RPEC members drive upwards of 3 hours each way to access affordable quality care. Many must stay overnight at a hotel because they cannot manage driving such long distances. This situation is untenable and is taking a financial, physical, and emotional toll on our seniors. We also support your focus on increasing fee reporting requirements and ensuring greater transparency in billing. These measures will provide seniors with greater security in planning for necessary medical expenses. Thank you for looking for viable solutions to increase healthcare cost transparency, improve cost containment, and broaden access to quality care.
Thank you, Claire. And as the PEB chair, I will certainly pass those comments on to Dave and Lou and others, but thank you for coming before us today. All right, and last we have Adam.
Next up is Adam Zarin, followed by Katerina LaMarche.
Great. Thank you, Director Birch, members of the board. My name is Adam Zarin. I'm the Director of State Government Affairs for the Leukemia and Lymphoma Society. Our mission is to cure blood cancer and improve the quality of life for patients and their families. As you've heard earlier, at a time when more than half of Washingtonians have avoided seeking medical treatment or modified their use of prescriptions in the last year due to cost, any increase in the cost of care will only exacerbate problems for access, equity, and public health. Many patients will not start treatment if they face high healthcare costs. For patients, 4 in 10 do not, in fact, start treatment when they have huge out-of-pocket costs. And 42% of cancer patients will deplete their savings in the first 2 years after diagnosis. Some will turn to friends for loans or gifts, but most will accumulate medical debt. In short, high healthcare costs are becoming medical debt. And again, 1 in 3 Washingtonian households have an individual with medical debt, like Rachel. Rachel was diagnosed with lymphoma at 21 while she was attending college. She had recently purchased a plan off the exchange, but the tests for her diagnosis were out of network and came with huge costs. She was forced to move back to have support of her family. Still, some of her medical bills ended up at her old address, and they soon went into collections. She used a credit card to afford regular expenses like gas and groceries. With her treatment center now an hour away, the debt accumulated. Today, she is still paying off the credit card debt from almost 10 years ago, which has harmed her credit score. This is the context we would encourage the board to think about when assessing the benchmark. In a highly consolidated health system where patients like Rachel have little choice and price has little relation to the quality of care or patient outcomes, the board is responsible for keeping a target that would at least prevent care and coverage from getting even more unaffordable. A statewide benchmark must incorporate experiences like Rachel's, their ability to access care, and their ability to pay. Otherwise, we'll continue to see Washingtonians accumulate medical debt.
Thank you, Adam. Katrina, I believe you're next.
Hi, yeah, thank you. Katerina LaMarche with the Washington State Hospital Association, sort of in line with the earlier discussion about understanding healthcare costs and improving affordability. We've really thought a lot about the board's work in doing this, and we understand why the policy recommendations target hospitals because there is that proportional impact of spending on hospital-based care. But if the policy recommendations target hospitals, we think it'd be most helpful if they address what actually drives hospital input costs. When hospitals have really limited control over the majority of those drivers, like wages and pharmaceuticals, which have been addressed today, but these have also increased significantly in recent years. And we think we should focus on those input cost drivers if we want hospitals to be successful in making care more affordable. Right now, we have a lot of questions that we're struggling to answer when we consider what hospitals are actually able to control. The board's consultants found that most hospitals in the state have low or normal margins. So what are they expected to change? I mean, there's reduction of staff or the amount of care that's provided or the type. Where should the savings or efficiencies be found? Because if cuts right now are made to revenues and revenues are already low, what does that do to access and quality and services offered? So we hope that you'll consider these questions along with our past comments and recommended changes to improve provider data reporting and the benchmark methodology so that the effort to improve affordability is realistic and achievable for hospitals. Thank you.
Thank you so much, Katerina. And I'm sure that labor costs, both direct and indirect care labor costs, will be a subject of ongoing scrutiny in the kind of current times. Haley, I think we have one more. Don't we have an additional?
One more. Yep, John Godfrey.
John, good.
Last but not least, thank you, Chair Birch, members of the board. My name is John Godfrey. I'm the program manager for Washington Community Action Network and a small business owner of a framing studio in Seattle. As many of you know, Washington CAN has thousands of members across the state who are deeply impacted by high healthcare costs. Yesterday, a member from Whatcom County called me in distress about premium increases on exchange plans that she is dependent upon as a small business owner. I identify with this as premiums for my staff have gone up nearly 20% in each of the last 2 years. There are lower cost alternative plans, of course. You may be able to get away with that if you're young and healthy, but invariably these plans have limited coverage and very narrow networks with patients often unable to find providers willing to accept them. This problem is far worse in rural areas of the state, as has been mentioned multiple times. There's also churning in and out of Apple Health as a possibility, but even if you qualify, those plans suffer from the same narrow networks and provider reluctance. Regardless, access to behavioral and dental care is even more precarious. I would be remiss not to point out that even for the carriers that met benchmarks, they did so in an ecosystem of substantial premium increases and de facto loss of access for patients as they struggle to find providers or delay care even when they have access on paper. In sum, as advocates, public servants, and stakeholders, we must do better for patients and taxpayers in addressing issues from consolidation to medical debt. Given the data presented today, state budget shortfalls, federal uncertainty, the importance of policy levers such as reference pricing and increased state oversight of hospital mergers cannot be more apparent. Thank you.
Thank you, John. And staff, I'm going to just check one more time. We have nobody else in the queue, nobody else in the room. So at this point, I will close our public comment period. Well, board members, we are at the close of our meeting. I wanted to do a little bit of a 2025 preview, and if you'll indulge me just a bit, I do want to first thank the staff for this fabulous kind of summation and meeting our requirements for our first public meeting. I want to thank all of our panelists for speaking up and sharing your concerns and your ongoing shaping of our work. So please, and all board members, thank you for attending. This really takes a lot of time and effort, and this is not just light thinking. It really requires us to focus and really concentrate. So I just really thank board members because your ongoing attention to all of this is critically important. This is my last meeting, and I want to just tell you all how I so appreciate Eileen and I, when we were from 2 different states many moons ago, heard the first presentations at a Millbank meeting about this work. And we became fast friends over the years. And really, when I think about how Michelle, under your leadership, and Michelle and staff, how you have moved this body of work forward, and how many other states have come along. And to our partners over at OIC and to our partners at the Attorney General's office, I mean, this convergence of work, especially with the stakeholders, so critically important. We keep doing this with this air towards curiosity, transparency, visibility, understanding. We all want really good healthcare, but we all have to really agree that we can do better than we currently are. And nobody's, we're not pointing fingers. We're just trying to understand and look at how we reshape things, what government things need to get out of the way, what needs to happen around wage controls, or what are the appropriate sorts of pricing things that need to go on, and what can we do to keep trying to live up to that benchmark. So I hope that this board carries forward with trying to understand what's going on, to move courageously with the legislature about those recommendations, to do something more, because I do think in the years to come, all sectors, large businesses, small businesses, we all have to get real about just stop wasting money and use it more efficiently. I do think we still are in a post-COVID kind of reconstruction. It's still occurring. And so I think this report today really is just a point in time. We have to be very careful that people don't say, oh, see, we're close enough to 3.2, 3.6, we're done. We are so not done. We have to continue on this journey, and I know you guys will keep carrying the torch. I'll be cheering from you afar as I'm holding a grandchild, of course, and working externally and at the national level on these very issues. So I know that we will move forward with God's speed, and to keep really impacting so that our clients, our Washingtonians, feel better about healthcare and their healthcare costs. A few other things, a few logistical things. I truly gratitude. There's been so much patience and understanding all the advisory groups. So just thank you all. Just know that we are a unique state. A lot of states aren't putting this level of energy in, but are still kind of just struggling with understanding basic things. And we are a little ahead of that. So thank you all. The staff are going to be great about putting up the recording and summary of this meeting. It'll be posted shortly on our website. This is our final meeting for 2024, but mark your calendars for January 30th. I'll be calling in to listen. There'll be an anonymous number, but from 2 to 4, I'm going to have to go through a week phase, but from 2 to 4 on January 30th. Meeting invites have already been sent out to all board members, and the details are available on the Cost Board's webpage. For anyone else who wants to mark their calendars. And I really hope that people have a very happy, safe holiday and just continue to stay steady and to just keep seeking to understand more as we go into more uncertain times. I'm really proud of Washington and all of you for this work. So carry on. And this meeting is adjourned.
I have a request, board members who are present, can we get a picture of Sue surrounded by?
Oh, I think that's lovely.
To mark her last day. You got it, Michelle?
Yeah, there's slightly better.
Oh,
Yeah.